Ladies and gentlemen, I'd first of all like to thank Joan and her colleagues at this lovely institution here for inviting me over to Northern Ireland. I always like coming to Ireland, and I hope that what I have to say will be sufficiently interesting to stimulate you all into further action and further understanding. The first slide I put up here resonates really well with the fundamental issue that we're dealing with this condition. Never mind the bollocks, here's the science. And it's written by Professor Luke O'Neill, who is Professor of Immunology at Trinity College Dublin. And what he's touched upon here is a very interesting process whereby scientific understanding evolves slowly, but initially, whatever is subject to that understanding has been attributed to dogma and misunderstanding. And very often the people who have constructed that dogma are very resistant to the scientific understanding which replaces the dogma that they have created. Probably the first person I should start talking about this evening, if I'm going to give you this narrative, is Professor Melvin Ramsey, whom I used to know very well. He actually preceded me at the Royal Free Hospital as a consultant in infectious diseases, bar one. He was a consultant in the 1950s, and I followed in his footsteps in the 1980s, and I met him quite frequently, usually in relation to the subject of ME. And he actually, next slide. It was he who described the outbreak of ME involving the doctors and other medical staff, nursing staff at the Royal Free Hospital in the 1950s. And he wrote subsequently an article in The Lancet which described a new clinical entity. And it was the leading article. And this leading article described severe fatigue, unrelieved by sleep, muscle pains, malaise with exercise beyond narrow limits, cognitive difficulties, spikes of fever, hypersensitivity to sensory stimuli. Now, the spikes of fever were something that I saw a lot of because in the early days, when I was looking after patients with infections, and sometimes when they didn't get better and they seemed to progress to ME, they also had the odd spike of fever measurable over the space of an hour or two, which would then settle down. And it's this which convinced me, as well as Melvin Ramsey, that this was a physical disorder. It had nothing to do with psychological disorder. As many of you in this room will know, there is this ongoing controversy as to whether ME is a scientifically definable disorder. And I think it's fair to say that the scientific evidence now shows that it definitely is. And so I've put science there in block letters. I've actually also put in the competing idea of psychological pathology, but there's no definable pathology, almost by definition, and therefore bollocks. And next slide. I promised that I'd stimulate you sometimes, but anyway. One of the earliest indications that, to me at least, that ME was a physical disease rather than a psychological disorder, as is promoted by some members of the medical profession, was this curious entity, a curious tendency for the immune system to remain active inappropriately. And what I've illustrated here is two graphs. initially those graphs coincide. A healthy person in blue and the ME/CFS patients in red. With a triggering infection, which is usually the case, you get an immune response which reaches a certain level. And in the healthy people, that immune response clears the infection, and then the blue line indicates the immune system settling down and the immunological activation settling down as well. Whereas with ME/CFS patients, something seems to interfere with the complete resolution of the disease process, and the immune system remains active and inappropriately and often hypersensitive to really quite harmless stimuli. One of the first papers which tried to maintain the psychological paradigm to explain this illness was written by two psychiatrists, McEvedy and Beard, and their paper appeared in the Medical Journal in 1970. And just to recap from the abstract they wrote, from a reanalysis of the case notes of patients with royal free disease, it is concluded that there is little evidence of an organic disease affecting the central nervous system, and that epidemic hysteria is a much more likely explanation. The data which support this hypothesis are the high attack rate in females compared with males. And I know that's going to enrage at least half of you present, because this is an absolutely nonsense conclusion to reach. And it's typical of the slightly airy-fairy psychiatric view of this illness. And anyway, sadly, that particular mindset was promoted a lot of difficulties in the management of patients with ME. We see, for example, with general practice sometimes, complete misunderstanding of what's going on with patients. And I've collected, next slide, I've collected a series of statements from patients to indicate the experiences they've had. It's all in your mind, forget about your body, okay? You have an abnormal illness belief. It's your buried guilt, dig it out. You should get pregnant. I won't go and elaborate on that one. Go to the gym more often. Now that's actually like telling someone with a broken leg to go and actually exercise the leg and it'll fix it. Why do you feel the need to vomit? This is a lady who had long-standing what's called mast cell activation syndrome, which is a complication of her ME, and she was perpetually nauseated. And the cause of her perpetual nausea and occasional vomiting was mast cell activation. But somehow or other, the GP she saw initially decided that this was something to do with her deep-seated need to vomit from time to time. And again, that's a sort of classic, rather daft psychiatric approach to the situation. You need more orgasms. Well, I won't elaborate more on that one either. But anyway, all of this, to continue the theme that is indicated by the title of that book, this is bollocks. So, next slide. One of the most interesting characters who is really obsessed with the idea that both ME and long COVID have psychological causes is a well-known psychiatrist who I won't name here because he's very much prone to suing people. But anyway, the Guardian journalist George Monbiot caught COVID infection, and then that progressed to long COVID. And he described this in The Guardian, for which he writes frequently. And because he described the symptoms of long COVID in The Guardian, really, to provide information on the illness and to basically describe what it meant to him, he was accused of being a super spreader of long COVID by this well-known psychiatrist, because merely describing the symptoms of his illness meant many people got it from reading his description of the illness. Now, this, of course, is bollocks as well. Now, if I were to apply that logic here and now and tell you all what the symptoms of dysentery were, some of you would have to leave the room rather quickly. And it's, the psychiatrist was basically employing this idea that many people are so suggestible that if you tell them that their headache or their tummy ache is due to some emotional trauma 10 years ago, they want people to believe it. But that's not necessarily the case. I mean, certainly the mind and body are very closely interactive, but many diseases which we're prone to are actually basically physical and don't owe anything to psychological disorder. There are certainly some diseases or some disorders where genuine psychological disorder does give rise to physical symptoms. And I suppose the real wake-up call in that respect was in soldiers who were suffering from shell shock in the First World War. They were not damaged physically, but they'd had the most terrible experiences. And so they developed basically post-traumatic stress disorder and had physical symptoms which arose from that. But that's a mechanism which is well understood began to be understood in those days. But to actually try and pull in that particular theory and apply it to ME and long COVID is completely incorrect. So, next line. The PACE study. Well, I can only bear to put up the PACE study, the 3 words of the PACE study, because really this is one of the worst examples in print of the psychological paradigm attempting to be promoted as a genuine, attempting to promote graded exercise and cognitive behavioral therapy as appropriate treatments for ME, chronic fatigue syndrome. And suffice to say that what appeared in print and written by the people who ran this study and what appeared anecdotally from multiple sources in patients who'd been recruited to the study was very different. Next slide. One of the complaints that many patients made was that they were basically coerced into providing answers which didn't necessarily tally with the way they felt after receiving cognitive behavioral therapy. And although I'm sure an anti-tank weapon wasn't pointed at every patient in the study, this is actually lifted from Monty Python. But be completely honest now, has graded exercise therapy made you better? Well, that is a clear indication. It's a wonderful sort of way of describing the extraordinary duress that many patients recruited to the PACE study were subject to in order to provide the right answers. So next slide. I've been fairly sort of robust about criticizing the PACE study and saying that it's rubbish. Well, it is rubbish. If you really want to read a very good sentence-by-sentence takedown of the PACE study, this edition of the Journal of Health Psychology, which is a special edition of which David Marks was the editor, does dissect the PACE study and show it for what it is, which was nonsense. Next slide. Now, well, I've taken you through examples of bollocks. Now I'll take you to some science. The big issue is whether or not you can define scientific changes in patients with ME. And one of the earliest studies which definitely shows this was done in 2016 over in the United States by Maddie Hornig, who's actually a psychiatrist. And they showed that there was a markedly disturbed immune signature in the cerebrospinal fluid of cases that is consistent with immune activation in the central nervous system. So here's the immune system activated for reasons which are not fully understood and going on being activated, as I've set out earlier in the talk. Next slide. Here's another study which again shows neuroinflammation in patients with chronic fatigue syndrome from Japan. Their conclusion was that neuroinflammation is present in widespread brain areas in CFS-ME patients. It should nowadays be ME-CFS, and was associated with the severity of neuropsychological symptoms. That's good science, basically indicating an abnormality which correlates with the symptoms of the patient. Next slide. Probably one of the earliest and most interesting studies which was done, which completely defined the difference between patients who are so-called deconditioned and patients with ME, used this piece of kit here, which is called a bicycle ergometer. As you can see, it's basically an exercise bike, and the piece of kit in the bodywork actually measures the amount of energy being delivered through the pedals. And this chap is wearing an oxygen mask, and the oxygen he's taking in is being very carefully measured through a demand valve. The energy that is being delivered through that through those pedals can be measured on the blue, it can be indicated on the blue line. And this chap is pedaling as hard as he can. And the amount of oxygen required to deliver that energy is indicated on the blue line slightly below it. Now, one of the interesting features of exercise to a certain point is that everyone in this room will know that if they really push themselves, they reach a certain point where they become very breathless and they can't go on. And that point is indicated by the oxygen supply actually peaking and not actually going any further, not stopping, but peaking at that level. And if we go to the next slide, what generally happens is that the energy delivery through via the muscles into the pedals, that peaks also and flattens off and very soon starts coming down. Likewise, oxygen delivery starts coming down as well. And oxygen delivery is basically very much related to the anatomical restrictions of the size of your heart and the efficiency of your lungs and the efficiency of your circulation. The likes of Mo Farah and all these top-class endurance athletes, their anaerobic threshold is not there. It's basically sort of up there somewhere. Now, if you take a normally fit person and you render them deconditioned by getting them to sit around for 6 weeks, you'll find that on day one, when you check their anaerobic threshold, it's there. And the next day, you put them on the bike again, and their anaerobic threshold is, again, a bit further up. In other words, this fit person who's been deconditioned, that person has got a little bit fitter as a result of the exercise he's taken or she's taken on the exercise bike. Now, if I take a moderately affected ME patient and put them on the exercise bike on day one, it's likely to be here, equivalent to the deconditioned person, but the next day it's down there. So exercise to the anaerobic threshold is a very, very good way of indicating the presence or absence of ME. And this is a very, very good way of defining what's wrong metabolically with ME patients. And you get some patients who are so badly affected that they can hardly turn over in bed without hitting their anaerobic threshold. And some patients, interestingly, describe what they feel is air hunger. And that air hunger is generated by the presence of lactic acid, which most of you will actually have experienced if you sprint, say 50 yards, 100 yards. I had to sprint for a bus about 2 or 3 weeks ago, and when I got to the bus, I was very breathless, and I wasn't, I was mechanically at rest sitting in the bus, but still like this. And doing that simply to get more oxygen in, to clear the lactic acid which had accumulated as a result of hitting my anaerobic threshold. Now, many ME patients hit that anaerobic threshold without even having to sprint. They can walk across the room and they get short of breath and feel exhausted and want to sit down. And as I say, many patients describe to me that phenomenon in conjunction with this curious description of air hunger, which is simply your body requiring more oxygen to clear lactic acid and not actually to provide more muscular activity. So, next slide. These are 3 papers which, the first 2, this paper here was partly authored by Mark Van Ness, who I met on 1 or 2 occasions, and he was the first person in his laboratory with various others, including Christopher Snell, who's indicated there, indicating this curious inability for ME patients to improve their anaerobic threshold with exercise. And furthermore, the opposite was happening. Their anaerobic threshold was going down. And anyway, Betsy Keller, Columbia University, she actually repeated this work obviously with different patients, same protocol, different equipment, but got exactly the same results. And the other final sort of indication that there's something wrong with the metabolism of the muscles of patients with ME was this study here, which was done on isolated muscle biopsies, which were stimulated electrically in the laboratory several times, and you can make the muscle twitch several times with inputs of electric stimuli, and the muscle from patients with ME lasted much less time than the control muscle samples from volunteers who were otherwise perfectly fit. So here is an example of a piece of muscle taken from a patient and subjected to electrical stimuli, twitching, 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 and then the twitching stopping really quite rapidly and producing lots of lactic acid much sooner than a patient with a so-called control patient who's otherwise healthy. Right, that's science as well, as opposed to the other term. Okay, so next one. Current treatments. Basically, I suppose one of the frustrations is that we don't yet know the exact cause, but nonetheless, what is quite well known are the various physiological abnormalities which occur with ME, and you can correct those physiological abnormalities quite effectively in some cases. Now, one of the most impressive physiological abnormalities which occurs in the more severely affected patients is a reduced blood volume. And the reduced blood volume almost certainly has 2 fundamental causes. One is that the pituitary gland is unable to produce sufficient levels of ACTH, which then has a knock-on effect of not producing enough in the way of the cortisol hormones, which maintain the level of salt and water in the blood, which is necessary to maintain blood volume. So in other words, the kidney is not being told to retain salt and water, and the result is a reduction in blood volume. And one of the clinical features of this is constant levels of urination, up to 2-3 liters of urination a day. And also, these patients tend to be very thirsty. It's often quite important to actually ask patients whether they're thirsty, and sometimes they don't feel that that's necessarily a symptom they need to report. And so asking about their thirst is actually quite important. And often they will say, yes, I tend to drink a lot, but I also pee a lot, which is essentially a feature of this hormonal deficiency, low cortisols, which have been found quite frequently in patients with this condition. The other hormone, which is less frequently found to be deficient, is the hormone called antidiuretic hormone, which, if you find that that's low, that produces a syndrome which is rather similar to what's also called diabetes insipidus. And antidiuretic hormone also tells the kidneys to hold on to water. And if you haven't got enough of that, your kidneys will just lose the water, and the net effect is prolific urine production and a thirst to go with that. And generally speaking, the blood volume remains low. A low blood volume, unfortunately, will cause considerable problems with orthostatic intolerance. The full-blown term is postural orthostatic tachycardia syndrome, because when you're actually lying in bed horizontal, blood flow occurs in the horizontal plane. It's not opposed by gravity to any great extent, but as soon as you stand up, blood returning from the legs to the heart is opposed by gravity. And if you've got a low blood volume circulating in the first place, that return of blood to the heart is going to be significantly reduced. The heart will then also produce rather less, pump out less blood than it should. And the result is less blood flowing through the brain, and in some cases fainting, in some cases just purely nausea. In other cases, some patients literally can't stand up at all because they get so dizzy and faint that they spend most of their lives horizontal. So the treatment for the low blood volume is very straightforward if one can obtain it in a patient who's in hospital, and that is intravenous saline infusion. The other thing that needs to be done for such patients is an endocrinologist needs to look at them to see which of the two hormones are lacking. Is it the ACTH and cortisols, or is it the ADH which needs to be treated? Next is mast cell activation. For some reason or other, the mast cells, which are an integral part of the immune system, which govern most of the functions of allergy, these mast cells tend to be overactive and inappropriately stimulated by even harmless types of food, particularly proteins of various kinds. And the result in some patients is terrible digestive symptoms and sometimes hives. They get very, very itchy when that happens, and they get abdominal pain. They sometimes feel very nauseated. And in the worst cases, these patients have such a poor nutritional intake, they lose lots of weight, and the worst case scenario is they need to be admitted and be tube fed, and the very worst case is when they need total parenteral nutrition, which is providing them with their nutrition into the bloodstream rather than into the gut. Neuropathic pain is another feature which is a big problem in many patients. And here again, there are various approaches which are useful. Gabapentin helps some patients, but the trouble with gabapentin is it also causes postural hypotension. CBD derivatives can be helpful. I remember a patient about 10 years ago coming to see me. He said the only thing which fixed his bone and joint pains was smoking a joint. And the trouble is, you know, it's not something you can tell every patient to use. Lignocaine infusions are also quite helpful. But there again, the help that is provided by lignocaine infusions is variable from patient to patient. Finally, B12 injections do seem to be helpful. And B12 injections are not because of B12 deficiency, but simply because vitamin B12 does seem to have a rather unique ability to mop up some of the inflammatory cytokines, which are a feature of this inappropriate immunological activity, which just runs on and on and on in ME patients. So next slide. What I've illustrated here in my final slide, firstly, is an indication on the left is a sort of compressed diagram of the bloodstream. The red bit are the arteries, and the sort of network between the red and the blue are the capillaries. Now, the capillaries are basically the food depots of the body, as well as the waste disposal units. And they are absolutely minute. You can't really see capillaries properly without a microscope. And they're very small indeed, so small, in fact, that they will only admit a procession of red blood cells, single file, down the capillary. The diameters of the average capillary is such that the red cells can only get down them single file. Now, imagine what happens if your blood volume is low, and furthermore, if you have a disorder of the various reflexes which switch supplies of blood from one part of the body to the other. There is a curious mechanism which in normal health actually helps distribute blood to the parts of the body which require it at any given time. A bit like the National Grid. You know, I understand that the National Grid have people on standby when the FA Cup final is on, because when half time comes, everyone goes and switches on their electric kettle, and that requires much more electricity. And likewise with the amount of blood that you've got circulating in your body, there's not enough blood to provide everything for each part of the body at full stretch at any one time. And so what happens with ME patients is that because of this low circulating blood volume, you get a reduction in capillary circulation. And in addition to that, a recent work from Germany suggests that a lot of those capillaries are actually partially obstructed by micro blood clots, particularly long COVID patients. And so if you can imagine those capillaries, which are narrow in the first place anyway, being partially blocked, the supply of nutrients, particularly also oxygen, to the tissues is substantially reduced. And the general effect is that you're very near your anaerobic threshold at all times in all the other tissues as well as the muscles. And this is probably the reason why people suffer so much pain all the time, that the blood supply to their tissues, whether it be bones or muscles or tendons or other parts of the body, is reduced because of this low circulating blood volume. And there again, one of the things that one can do on a clinical basis is encourage people to drink a bit more water laced with glucose electrolyte mixture. And the whole point of using glucose and electrolyte in a mixture is that the presence of glucose in the right proportions will result in the electrolyte, the sodium chloride, which is usually what one uses, being absorbed more efficiently. And once that's absorbed, the water will follow. And so that's an indication of the basic pathology occurring in a way which is understandable and which is easily rectifiable. And of the few patients I've had who've had the good fortune to be admitted to hospital, they get normal saline, and their capillary circulation is vastly improved by that, and they feel rather better. And if someone asked me now or tomorrow what I would suggest that people have to try and alleviate many of their ME symptoms and set them on the road to recovery, I would suggest that what they need is an intravenous line in place for several months, during which time they receive normal saline up to 2 or 3 liters a day, and they will feel much, much better. And it's a frustration I have with many hospitals when patients get admitted, that I can't persuade them to leave the lines that they've got in. But anyway, I think to finish off, I can tell you that I think that within the next 2 or 3 years, we're going to see some real breakthroughs in the understanding of this condition, and some breakthroughs initially in understanding what needs to be done. And what also needs to be done is to try and persuade those doubters out there that this is a real illness and that it needs proper education and proper medical care. So, thank you.